we'll go through everything about the concussions today in general. Our goals here, basically describing a concussion. If we have some, well, actually, what is everyone here? I know you are kind of a teacher or a coach for some different sports. What are you guys' interest? Are you a teacher, mother? What is it? What's your interest here today?
I'm currently recovering from a concussion, so I just thought I'd see what I could learn.
You can learn about it, see, hopefully that's going okay for you. We'll talk about a few things today. Anything else? You said teacher.
Second grade, so playground injuries.
Okay. All right. So maybe some things you can recognize at school and stuff like that. And then also looking into some grad students, some other medical type of stuff, future medical stuff as well. So our goals, we'll talk about what exactly a concussion is. We may gloss through a few portions of the physiologic stuff unless you guys want to get into the details. How the concussions are commonly treated. And then there's always this question of how we can prevent concussions if we can. And then the Ohio law, which was April, I guess I should probably say it's not really new anymore, 2013, about the Ohio law on concussions with youth in sports, on how they now need to, there's some certain regulations about those that experience or show signs or symptoms of a concussion. So first and foremost, I guess with every talk, we talk about the definition. So you can read it yourself, but the big issue here, or the big thought is, it's a complex, so it is complicated, pathophysiologic process. So it's more of how the brain works rather than structural damage. That's how I refer to it as patients, saying a concussion is changing how your brain works, where you may be the symptoms that you know of, confusion, headaches, and not structural stuff like a skull fracture, a bleed in the brain, stuff like that. So sometimes those injuries mimic a concussion. So that's why sometimes if you hear about people going to the emergency room, they may end up with a CT scan or an MRI. But CTs or MRI scans for a concussion are generally normal, because structurally there's not that pathology. It's how it works, more the physiologic state. Here is the definition by the Concussion in Sport, the fourth consensus statement for concussion in sport gathering, which is the world's experts get together about every 4 years. We're actually getting together, I believe, next month. If you wanted to go to Berlin, Germany, and go to that, but they get together about every 4 years. They come up with this consensus statement. This was their definition at the time. Again, you see the term complex pathophysiology. And basically, we'll go to the next one. The things that they mention as details oriented with this, it can be caused by a direct blow to the head, but also the face, neck, or elsewhere on the body. So the assumption that it has to be a blow to the head or an injury to the head is not necessarily the case. So you can get other injuries from a whiplash type of thing with your head kind of maybe not direct contact with your head, but you get those forces get transmitted to your head. It generally results in a rapid onset. So that's what we had always thought. In general, if you have a concussion, you have immediate symptoms. Over the years, we became aware that it can evolve over the course of minutes to hours. So nowadays, it would not be completely unheard of to say, well, I fell, hit my head, I didn't think much of it, I felt I was fine, woke up the next morning and I had a headache, or I had problems sleeping that night. So it's not something where you automatically have symptoms right when it occurs. All right? Other things here, this is what we're talking about, a functional disturbance rather than a structural injury. That's again why you may have a CT scan or an MRI. That does not mean you do not have a concussion. We would expect those to be normal with a concussion. And lastly, this is one that you may see as well. It may or may not involve a loss of consciousness. So years ago, oh, did you lose consciousness? No, nope. Well then, okay, you're fine. We don't believe that to be the case anymore. The concussion can occur whether you do or do not have a loss of consciousness. Any questions with that so far? This is going to be my open. You are free to ask questions at any time. Just raise your hand and we'll do it at any point. Feel free. So some of our incidence type of stuff on terms of when they occur, what sports they occur in. The estimate, 1.6 to 3.8 million per year of sport-related ones. So obviously that's quite a wide range, but I would probably venture to say it's probably on the upper end there in terms of all the youth sports that are going on, whether it be soccer, basketball, football, and playground injuries of all the concussions that occur. It, I'm sure, is in the higher range there. Again, this is what we're talking, 5 to 9% of sport injuries are thought to be due to concussions. The 30% of the concussions in the youthful or high school and below population are thought to be sport related. This is the order of most likely or percentages of concussion or risk of concussion. So football has the highest number. Now it's not actually necessarily the highest percentage, but when you count in numbers and everything else, it's the highest number, followed by wrestling, girls soccer, boys soccer, and then girls basketball. Yep.
What about boxing? I mean, people just beat the crap out of themselves.
I think that's probably by sheer number, you wouldn't necessarily have that be the case. Now the thing with boxing and what we may talk about later is maybe the new frontier in this concussion stuff is actually subconcussive blows, meaning you don't get diagnosed with concussion on each and every event or match, but you have these subconcussive blows which can lead to some potential long-term issues. But I think in that case, that would be kind of sheer numbers oriented.
I'm surprised to see girls soccer before boys. Are we more aggressive?
My impression is it actually occurs early on in that maybe they're not as physically mature yet, and then it's the strength, falling, slipping, plowing into people type of stuff. To be honest, when I see concussions though, what I see most frequently cause them is not soccer ball type of stuff, but someone going up for a head ball and hitting someone else's head, going up for a head ball and hitting someone else's elbow, stuff like that where you hit something that you're not expecting to hit. And rates do seem to be higher in games per hour, or concussions per hour played in a game is higher than practice. So whether that's that level of intensity that goes up for a game, you're more likely to take risk, whatever it would be, but the chance of a concussion or rates are higher in a game than it is compared to practice. Here's the pathophysiology. So we'll run through this quick. We don't have any, unless someone has a great need for physiology stuff. The great issue, or the big issue here is there is a mechanical disruption of the neurons. So some force, rotational force or traumatic force to the neurons stimulate a release of potassium extracellularly in the brain. When that occurs, it causes this big cascade of glutamate, potassium, the calcium inside the cells go up. Then the cells then have to try to correct the elevated potassium outside of the cell, elevated calcium inside the cell. So they have to have these channels to flip those around. That takes energy. And so that is where they're requiring this ATP or the energy, except there's only a limited supply to the brain, and thus it can't meet the demand that the brain wants to try to correct those, injury levels of potassium and levels of calcium. So here's how I kind of summarize it. This one. Here. Cerebral blood flow. Oh, go ahead.
So the idea is that since the brain is now finding this increase in ATP, and so is that then there's not energy available for normal functioning, and so is that the thinking of what causes a lot of the symptoms being less than?
That is how I would describe it. So the idea that your brain is asking for more energy, or ATP, to put these ions back where they're supposed to be, but at the same time that that's occurring, the changes that occur cause vasoconstriction in the brain, and you actually get lower blood supply to the brain at the time the brain's asking for more, or would like more. And then that mismatch, what they would call that metabolic demand, increases because you want to fix those problems, but the blood flow reduction occurs. That mismatch is what we think causes many of the symptoms, or the dysfunction of your brain, meaning you can't think quite right, your balance is off, or you have a headache. That mismatch is thought to be a big factor. Now, I have not seen any specific studies on how they can try to correct that mismatch. People are dabbling in the ideas of saying, why don't we do some type of thing to increase blood flow or increase blood sugar to the brain to give it more energy to see if that will speed up the recovery. Those are all kind of very early phases type study stuff.
I've heard from just people talking with especially boxers and stuff, that when they suffer a concussion, they then recommend increasing sugar intake, like apple juice or something. So is that the idea?
That's the idea. I've not seen any actual studies to say that it helps, but that's the thought. We're going to increase your blood sugar level to provide more glucose to your brain, that is basically energy, to maybe help with that correction. So I've not seen the studies, but yes, there's those type of ideas.
So if somebody, would there be any harm in doing that?
I would not know of any harm either. You could try it. Someone said, I would say after a concussion, we would say, make sure you eat and drink appropriately, which can kind of help with symptoms. Do we know that that helps with increasing the blood flow to the brain or that other type of stuff? No, but it is something we ask them to do. I'm not, in terms of evidence-based type of stuff, I do not recommend that you say, okay, you should have sugar or something following a concussion immediately. I could see it potentially helping in the future once some studies come out to say, okay, yes, we should be doing this. But I don't know of it to hurt either.
And go ahead.
Do we have to be careful with a diabetic child?
Yeah, you would. There is that issue there that so this may be kind of what's leading to the idea of this blood glucose. There's been case studies in terms of individuals with diabetes that have low blood sugar or high blood sugar at the time of this injury, that it does affect the diabetic kids do have in some studies a prolonged recovery. And so is there some factor in glucose metabolism that's associated with it? In terms of making sure there's glucose available, I would say in terms of doing it for kids, I would say at the time, if they are confused or extremely out of it, I wouldn't force stuff into them. But if they're saying, oh, yes, I have a headache, I would say eat your regular small meals throughout the day as kind of a supply. I don't think there would be an advantage of trying to get it higher than what you would consider normal. If it's low, you may have an advantage to get it to normal.
In your experience, have you had patients report an increased interest in high sugar, high carb, high glucose?
Have a dietary change, meaning if they have a concussion, they're like, I feel like I need to eat more type of thing?
Or that they find that they're wanting more high sugar, high carb foods than they typically would.
I have not specifically heard that from patients. Now, I don't specifically ask it each time either. I do ask, well, how are you eating and drinking? Doing okay there? Do you have any nausea? I ask them those questions, but I'm not specifically asking. I haven't heard it, but I don't ask. You notice them? Have you heard that other ways? Or do you feel that way yourself?
I have noticed that I feel that way, but I haven't heard anything, so I was just curious.
You can start a study there. The first one. So here, this is your quick summary of the physiology. So if you wanted to really get involved with it, you can. It's a complicated, this is my idea of saying it is a complicated, complex pathophysiologic process. All right, in terms of the actual diagnosis, so kind of grouping up into symptoms, something they're experiencing or they can tell you about, the physical signs that you can see, behavior or cognitive type of stuff, as well as sleep disturbances. Those are common groups of symptoms that we see with concussion, or people will group it into those, or have it into those groups. So visible signs, the stuff you see when you're watching TV or someone at a game, or you see someone, if they're loss of consciousness, that would be a potential concern or sign of a concussion. Slowed movements, this poor balance or poor coordination. You can see that appearance when they have kind of that dazed look on their face. Those would be things that you can see yourself that would raise the concern for a concussion.
So that's a classic combative knockout. Is every knockout a concussion?
I would say every knockout would not necessarily be a concussion, but I would treat it as such until you know that it's not. But when we say, wait, we don't know that symptoms occur immediately, so if you're saying, wait, that could occur minutes later, hours later, so you're not going to necessarily know whether it is or is not until later. So in which case I would say get back to the point of treating it as a concussion. I would say most sports medicine or concussion type of physicians would say, is every person that get knocked out end up having symptoms of a concussion down the road? No, but I think we consider it a symptom of a concussion, so we would treat it as such. Big ones here, the ones I see most frequently: headache, dizziness, that balance type of problems. That's a common one. Sometimes I just come up with the thing, I just don't quite feel right, where the fogginess is sometimes the word that is used, but they just don't feel quite right. Other symptoms: difficulty with concentrating, fatigue, if you're talking real slow, or if you're having problems answering questions quickly. Those type of things would be things that you would be concerned, would be symptoms that we would ask about how you're doing with those symptoms over a period of time after a potential concussion, or when you have a concussion. Those are the symptoms we're watching for. So there's probably, you can see there's quite a few of them. So if you ever have a concussion, you go to the office, they'll say, how about these symptoms? They'll list about 20 of them, where you can go through and see which symptoms you have. So if you are on the sideline, neighborhood kid, something happens to, or at school, obviously initial first aid is what we would want to do first. That's those ABCs in terms of the airway, breathing, circulation type of stuff. But in terms of a concussion, if you get to that, the SCAT-3, so the Standardized Concussion Assessment Tool, number 3, that's what came out at this recent, well, now 3 years old, that concussion in sport consensus statement. They came up with a child SCAT, which kind of changes that slightly. It's very similar to what you have on the concussion recognition tool as part of that, even though the SCAT-3 is the specific questions that an athletic trainer may have. So they won't necessarily be on the concussion recognition tool, but that same consensus statement or committee developed these in conjunction with kind of the recognition tool. Other things that you would do: balance and coordination aspects. That's where you see people on the sideline trying to balance on one leg, or they may be walking the tandem gait, so they're trying to walk heel to toe. Those are all measures to try to see how they're doing with their coordination with balance. And when we talk about the imaging for the intracranial injury, that's kind of the red flags that are on the recognition tool, like nausea, vomiting that's not controlled, a sudden worsening of symptoms. Those would be things where you're like, well, is that potentially intracranial bleed causing the same symptoms that a concussion causes? And that's where you end up with those kind of CT scans or MRIs. So let's do, in terms of the imaging though, not everyone with a concussion is going to end up with a CT scan. So 5 to 10 years ago when we first started this, if you went to the emergency room and said, well, I got hit on the head, I have a headache, I'm dizzy, I don't quite feel right, frequently you would end up with a CT scan. But after thousands and thousands and thousands, or a very high percentage of normal CT scans, we are getting further and further away from people getting CT scans for what would be considered a concussion or expected course of a concussion. Meaning you have those symptoms, you start to improve, you stabilize, you may still have a headache, you may still be dizzy, but they're improving or they're stable. Generally you won't get a concussion now like you may have 5, 10 years ago. You can save the radiation, save the cost. Other sideline management stuff where we're talking about removal from competition. So if you have someone who's dazed, confused, foggy, can't answer questions, dizzy, stuff like that, you're going to remove them from a potential new contact injury. With the new law especially, and this is something maybe over the last 5 to 10 years that have developed, no same-day return. Like I said, just 10 years ago when I was just starting my training, that was one of the things where if you cleared within 15 minutes, you could get back in. So nowadays that's considered, or it'd be against the general consensus. The other thing we try to do on the sideline is regular monitoring. So if you're at it, go ahead and have a question.
How long we have to observe the patient if we suspect he has a concussion?
So I would say when I talk to patients, say I have an athlete the last 2 minutes of the game. I'm like, oh, that's the last 2 minutes. You'd like to see them stabilize. If they are stable, that would be your first step, meaning that their symptoms are not getting worse over the course of a half hour, hour, up to 2 hours or so. If they can go home with somebody that is reliable, a friend, family, something of that nature that says, I can watch, and if you get confused or if you start stuttering or start something else happening, you could do something about it. Generally, I'm okay with them going home in those situations. So in terms of injuries, it's how well they have stabilized. If their symptoms are getting worse and worse, I would make it longer. If they're stable or getting better or they feel better, okay, that's kind of that signal to say, okay, you can kind of move on and not expect something more dramatic to happen. That's where the regular monitoring comes in. So at a football game, we'll do every 5 minutes on the clock, which ends up being every 10, 15 minutes or so. How you doing? Things any different, better? Watching for a dramatic worsening, which can be concerning for a more significant injury. So when I say for sleep, that was a common one. Don't let them sleep. Wake them up every 2 hours. Now, that's kind of changed in the fact that when that had happened, when we talk about the concussions, we'll talk about some of the treatment, is allowing them to sleep helps. So the idea of waking them up, once you know that they are stable, in that first hour, 2 hours, depending on how long their symptoms are, once they're stable, we would say let them sleep. We feel that we were doing more harm than good. You really didn't save too many people from a dramatic worsening, but every kid that you woke up every 2 hours, that first day their symptoms were terrible. And so that aggravated their symptoms. So generally, once they're stable, you know they're stable, let them sleep overnight. Here's some other things in terms of the Maddox questions. This was that original study 10, 15 years ago, where it used to be, hey, what's your name? What's today's date? How old are you? Those very simple, basic questions used to be our things to measure confusion. Then studies came out that said that's not real reliable. People with concussions still know their name. They still know where they're at and those type of things. Questions that we ask is, what team are we, if we're out on a away field, who are we playing? Who scored last? Did we win last week? Things that require some level of concentration seem to have done a better job in recognizing a concussion. So these are kind of those questions. It was the Maddox team that studied this, and these were those questions that they came up with. So the red flags that are kind of there on the recognition tool, that's that sudden worsening, intractable vomiting, severe intolerable pain, those type of things that would be going on. A lot of those things we talk about neck injury and stuff as well. So, questions? So, any other questions so far? So, say you've had your concussion or you've recognized a concussion, the neighbor kid has a concussion, something of that nature. What are some common things we would do treatment-wise? So, early after a concussion, physical and cognitive rest is thought to be the most beneficial. All right, so the physical exertion, when we're talking about that metabolic demand and supply mismatch, if you physically exert yourself, you're taking away supply to the brain, using it in the body, so that increases that mismatch. And vice versa with the cognitive exertion, you're using your brain, it's requiring more energy, and again, expanding that mismatch. So we want to avoid those situations, especially early on. So the physical rest part. So that's the boring part. No sports. You don't get to run around, you don't get to jump around, you don't get to do any of those activities that you may like. We do not do the exercise early in the concussion. We'll talk later. Actually, over the last few years, we've started to actually implement some exercise after a certain period of time that seems to enhance their recovery. But early on, those first few days especially, it is a lot of physical and cognitive rest. Now, I kind of word it as this: the first day or two, if you are tired and your head hurts and you want to sleep and take naps and not do anything, I'm okay with it. After that first day or two, a couple of studies now where we had things where patients were like, all right, you stay in this dark room, you don't see anyone, you don't do anything, you sit in there. They didn't get any better than those that did their activities of daily living. So after those first few days, you can get up, eat dinner, you can talk to friends, you can talk to your family, you can, I tell people if they're watching a TV show that doesn't require a lot of concentration and focus and doesn't hurt your head, short periods of that are okay, listening to music, those type of things. So your daily living, you get up, take your shower, you can go do all that type of stuff. So the sit in a dark room type of thing forever type of thing would be something I wouldn't necessarily recommend. First few days or day or two, a lot of sleep and stuff would be a good idea. The cognitive rest, I generally, so schools start, and this is always a tough time because they have school at the time. A day or two off from school, I think, is reasonable to do while their symptoms are most severe. Again, years ago, we used to have 3 days off, 5 days off, something of that nature. I am much less likely to do that now at this point, in that studies have shown that that does not improve their outcome. It just gets them further behind in school, or it gets them it keeps them from adapting or tolerating their symptoms at school. So a day or two, I think, is reasonable. Sometimes I have them start back at half days, where they can sleep in the morning if they're still very tired when they wake up, or wake up with a lot of symptoms. Go in the morning or the afternoon. More often, I'll do something where they get frequent breaks during the day. The last 10 minutes of each class, go down the nurse's station, close your eyes, it's quiet, something of that nature to control your symptoms. I tell them I don't want your symptoms escalating throughout the day. You need to take breaks to keep that from escalating. That's generally what I would recommend. Early on, sleep, that's a good combination of physical and cognitive rest. So I don't do a whole lot there in terms of encouraging sleep early on. So sleeping 10 hours, 11 hours, 12 hours, 13 hours, 14 hours, I've seen all that. Those first couple days, I think it's fine. You may feel, but if I ask patients how they feel when they wake up, if you are waking up and you have a headache or you still have symptoms first thing, I think your brain may want more sleep. So if you wake up and you're like, oh, I feel good, but I develop symptoms over the course of the day, that would be kind of that common progression on a recovery from a concussion. So first feeling good, first thing in the morning is commonly what we would see first, after a good night's sleep. Sometimes I get the thing where they have problems falling asleep at night, but then they're taking naps during the day. So then we start saying, okay, let's try to eliminate naps second half of the day or afternoon, so then that you can fall asleep overnight and try to get your sleep through the evening. Here's some home activities, kind of some things we hand out where it's talking different stages depending on the severity of symptoms. Early on, it's, okay, listen to music, quiet, to progress to half hour of TV, listening to music, talking to people, then an hour of TV, talking to people, maybe talking on the phone, stuff like that, where you gradually are increasing your stimulus, concentration, or mental stimulus. Driving type of restrictions, so that sometimes I get a question with that. I generally say it's whenever you're, safety driving. If you're able to concentrate on the road, you're not able, if you are unable to focus and you zone out obviously during driving, that would be an issue. So once you're able to do those things, we generally say you're okay to drive. The big ones are drowsiness and concentration. And then starting with the shorter distances seems reasonable. Making sure you can do that. Make sure it doesn't aggravate your symptoms as you're driving. So when, wait, I felt fine, but now I'm having a headache and you can't concentrate, obviously that would be an issue as well. So, say your concussion went well. You had symptoms early on, the symptoms diminished as you got your physical and cognitive rest. You were able to do your daily living without any symptoms. You don't require any medications for the headaches. Everything's good. No issues for a full day, once you have that full day of no symptoms, then you would start what we call this return to play protocol. And we'll talk about that on the next slide here. But you can't take medications for, you can't be saying, well, I don't have a headache, but you're taking ibuprofen to not have a headache. So I say you have to be on your baseline medications that you've been on prior to your concussion. If you don't have any symptoms with that for a full day, then you start the return to play steps. Which are these? Well, which are those? So the first one, I kind of don't consider it a step, but no activity, that's your step 0. First step, after you've had no symptoms whatsoever, light aerobic exercise. So a lot of times it's stationary bike. You do that with your athletic trainer at school. Second one is a sport-specific exercise. So if it's soccer, it may be some ball handling with a little higher exertional level than the stationary bike. So I consider it kind of a moderate exertional level, but you're also maybe doing some lateral movements, some jumps, something like that to make sure that doesn't aggravate your symptoms as well. And then non-contact training drills. So that is full exertional type of stuff. Anything in your sport that doesn't require contact, you can do. You would be sweating, you would be having a high exertion load, make sure that does not aggravate your symptoms either. The next one would be a contact practice. That goes okay, then would be a return to play. So you can see, even if things go well, one day at each step, it's a 4 or 5 day process. All right, and that's even once you're symptom free, then you get to start that. So that's sometimes what's frustrating to coaches or athletes. They'll say, well, I feel fine, all right, I'm ready to play tonight. Like, well, we got to go through these steps. When you're going through the steps, we talk about you want to proceed one day at each step, and you get to progress as long as you don't have any symptoms on those steps. If you do get symptoms on one of those days, you're going to stop, get symptom free for a full day, and then start back at the step below. And then you kind of progress up from there again. And here's kind of our little note that we would send home with athletic trainers. Step 1, step 2, step 3. Here, sometimes when I am working with athletic trainers, say they're at a school, I'm not necessarily going to see them every day. So if they're symptom free on a Tuesday with the athletic trainer, but they call on Wednesday to get an appointment, I don't see them till Thursday or Friday. I let them start the steps under the guidance of an athletic trainer on their own, but I still want to see them before they do the contact, which is step 1. That's more out of, I guess, convenience for the patient. I don't want them waiting 3 days without symptoms if they have something coming up that they feel that they're ready to participate in. That's what I'm talking about there. So some other testing that you may have heard about. So the fancy computer tests that do neuropsychological testing or neurocognitive testing. The idea with this is does people's cognitive recovery occur at the same time as their symptoms? There's some studies that say it does not, so that's the idea of these neurocognitive assessments on the computer, that maybe the patient doesn't have any symptoms, but cognitively they're not back to normal. So we're going to wait until they're cognitively back to normal as well before they go back into contact. Now the issue with these neurocognitive tests is there's never been a study that I know of that says it improves outcomes. But the problem is now so many people are using them, it's probably almost like a standard of care type of thing that a lot of people are doing the neurocognitive test on computers. So Impact or CogSport would be kind of our Headminders. Those are 3 common computer programs that people use. There's the traditional paper and pencil. The issue with that one, that's about a 2 or 2 hour long test. And then it's a 2 hour long evaluation and going over with the neuropsychologist. So we don't frequently use those except for severe cases or prolonged cases. The computerized neuropsych Impact is what we use. Those other ones, those are widely available and much more commonly used. So at schools, when they say, oh, we did baseline testing, it's generally one of those. They sign up a school, the school has every athlete do the test, and then afterwards they can compare it to their previous level. So say there's questions of returning to play. What are the risks or potential risks? So when I talk to patients, the big things that I can say are the biggest reasons we pay attention to this. One is second impact syndrome. And I put the possibility of second impact syndrome because there's not really a study to prove that it occurs. But there is case reports of patients that say they had symptoms at the time or were reporting symptoms to a friend. They have a second injury. The brain swells up, results in severe catastrophic, meaning death or ICU or permanent damage due to that brain swelling. The issue why I say possibility is we don't know that they wouldn't have got it anyways just with the injury itself. But there is those cases where it seems to be someone had symptoms, a second hit that you wouldn't expect to cause those severe symptoms occurs. So that's that second impact. Is that too confusing on that? That's okay. Athletes don't think they're going to have second impact syndrome. Like, that's not a big deal. It's not going to happen to me. But this one with the significant worsening of symptoms. So when I have a patient in the office that says, oh, I've seen 2 doctors, I've had symptoms for 3 months. Most of the time of those, they'll say, I had a hit on the head or something happened. I didn't think it was a concussion. I thought it was my allergies, or I thought I didn't get a night's sleep, or the lights were bothering me, and I didn't think it was something. Then they get that second hit, and then all of a sudden their symptoms go from a mild score of 5 to 60. And then all of a sudden those symptoms last significantly longer. So sometimes athletes may pay attention to that to say, you may not have a second impact syndrome, but you may have symptoms for 3 months, which is the rest of the season. So if you have symptoms, avoid contact. That's my big thing with athletes. If you have symptoms, you do not want to be playing.
Whiplash do that?
Yeah.
Whiplash is then.
So there would be something similar, meaning not a direct blow to the head, can cause concussive symptoms. So yes, there's probably unfortunate circumstances where they had a concussion and then they're driving in a car not doing any contact, and then they get in a car accident and all of a sudden their symptoms get dramatically worse. It's happened a couple times, unfortunately. And then that's the 2 issues that I see, that significant worsening of duration or worsening of severities. Things that I use to consider return to play protocol or return to play. So if an athlete has persistent cognitive deficits, like, wait a second, I'm not thinking the way I used to think, or my math homework is slower than what it used to be, that would be something where I'd say, well, even if it's a small amount, my concern there would be the second one would be a dramatic difference in cognitive functioning. And that would be a situation where you'd say, well, maybe you don't want to be doing contact sports or collision sports. Prior history of concussions, are the symptoms lasting longer and longer and longer? Meaning, oh, I had 4 concussions. My first one was 3 days, and then it went 6 days, and then it went 6 weeks, and then it went 6 months. I'd say my concern for your next one is that's 6 more months, or 12 months, or whatever it would be. So if they're lasting longer and longer each time, that's more concerning to me. Or if they're getting easier and easier to get, meaning now I'm just kind of having light tackles, or I'm falling down and I'm getting concussive symptoms, those would be things that would be concerning here. And then also the other thing I consider is what their age is and what sports they play. So if a 13-year-old that plays wrestling and football and lacrosse has 2 concussions, that's more concerning to me than a 13-year-old that has had a concussion from falling off the playground and an accident at home, and they play swimming and cross country and something else. So you may not necessarily, I would just use their potential risk for future concussions to consider how long they may want to avoid contact sports. Things are flying, okay. We'll go here. So additional treatment strategy. So if you have a prolonged recovery, say your symptoms aren't lasting that average of 7 to 10 days and they're lasting 2 weeks, 3 weeks, 4 weeks. Other things we consider, medications to help with the symptoms. This aerobic threshold conditioning, vestibular, and cognitive therapy will go here with these next few slides. So the medications. So if someone's having headaches, we can sometimes do stuff for headache prophylaxis, nausea, those type of things to help with concentration. Now with these medications, they have not been shown to reduce the duration. They're mostly to help the symptoms. But we can do that, or we do start those at some point. generally the 2-week time frame is a common time where we would consider starting. Aerobic threshold conditioning, what we were talking about earlier, is we don't have you rest forever. At 2 to 3 weeks, if you're still having symptoms, we have you start these aerobic exercises, stationary bike, walking on a treadmill, and we gradually bump up how much you do in terms of duration and intensity, with the idea we don't want to cause symptoms, we want to go up to the spot just before you have symptoms. So if you do get symptoms at, say, 20 minutes at a level 5 intensity, we say back that down to 16 minutes and do it at level 4 intensity, and then train at that level. There's 2 different groups that are doing some studies with that seem to show or have some significant evidence that helps with the recovery phase.
Can we go back a minute when you said melatonin on the other?
Melatonin has help with sleep, so that's a common one that we may use for patients that have difficulty falling asleep.
For some people, is melatonin time release, or is it the same for everybody?
Generally, for patients with concussion that have a problem falling asleep, so I generally use the regular Joe Schmo, quick acting or non-sustained release melatonin just before bed. So I say anywhere from 3 to 10 milligrams. So a 3 or 5 milligram pill, you can do 1 or 2 of either of those. Generally thought to be pretty safe. And that's the kind of the aerobic threshold conditioning. So that's that thing. Even if your symptoms weeks later, we don't still have you rest, we start having you do exercise and such now. Another thing we started adding is vestibular therapy. That's the stuff if patients have problems with turning their head, room feeling like it's spinning, dizziness, things such as that. There's been some evidence where it's the same idea with aerobic threshold conditioning. They'll be doing stuff where they're watching something on the wall and they're turning their head, or they're following targets through different tests. There's balance type of stuff that they'll do as they are looking at something on the wall or something of that nature. And again, there's some evidence that helps with their vestibular symptoms. Cognitive therapy, this is something we kind of use if someone is having prolonged symptoms and they're having problems at school. Doing a cognitive assessment, generally through speech therapy. They'll give them tips or tricks on how to help with their deficits or minimize their deficits at school. You know, coming up with a planner, ways to keep track of notes, keeping schedules, different things like that to help with their guidelines as they are returning back to cognitive exertion. So those would be kind of the big areas that we look at for prolonged symptoms. Post-concussion syndrome, so that's a kind of a fine line between prolonged symptoms and when does post-concussion syndrome occur. Generally, when I kind of look up all the different definitions, there's a lot of different people that have different definitions of it, but I kind of consider it the spot where your symptoms are not improving at the rate or in a route or in a way that we would expect them to do. So usually you're talking that 2-month, 3-month time frame where it seems like these symptoms are extreme or not reacting or improving with any of the therapies that you're trying. Those would be kind of these post-concussive syndrome issues. Other things to consider if you have a diagnosis of post-concussion syndrome, meaning these things can kind of mimic the symptoms. So if you're depressed, you may feel fatigued, you may have problems sleeping, but those would be similar to concussion symptoms. Chronic fatigue, the cervical injury is one where if you have headaches from a neck injury, that's persistently causing headaches, especially if you're doing reading, something with your head. That's another one we look at. Vestibular and visual function, those vestibular therapy type of stuff, where we're saying, is it isolated to the vestibular therapy? Is something inner ear? Is there something we have to look there that's causing the dizziness rather than the head? But that's something with vestibular therapy that kind of check with both of those. The CTE, what you hear about now, that's what you heard about with TV or the NFL over the years. The issues with this are we don't exactly know how many concussions you need, what causes it exactly. There is a very high association. I don't even think there's a direct cause and effect yet, mostly due to the fact that the people that have CTE now, they weren't keeping track of concussions years ago. So we don't really have good data on when they had concussions or when they did not. So for example, I guess this is getting longer, but Chris Henry was the wide receiver from the Bengals not long ago. He had some injury where he had an issue with a domestic dispute, fell, jumped out of a truck or something, ended up dying. He had chronic traumatic encephalopathy. Now the issue with that is we went back to look through his records with the Bengals in West Virginia in high school, and he had 0 documented concussions. So I think that's probably because they weren't paying attention 15 years ago, 20 years ago. He may not have told people every time he had symptoms or what have you. So it's going to be, I think, a little while before we have these long-term studies where we actually have numbers of concussions that people have had. The other thing about the chronic neurocognitive impairment, what we were talking about with boxing, there's an association between concussions and neurocognitive impairment. And if you take 1,000 people with 5 concussions and do a neurocognitive test and then 1,000 people with none, 1,000 people with 5 concussions are slightly worse than those that have none. Now we don't necessarily have a specific number that causes that, but that's the same thing that happens in subconcussive insults. That's boxing and actually soccer. That's the head ball rule that's out now. The USA Soccer recommends no doing head balls below age 12. I think that's probably actually going to increase at some point, because that's the issue I think soccer is going to have coming up, is even if you don't have these concussions, you're still ending up with potential neurocognitive impairment down the road. Mouth guards, what I'll say here, there's not good evidence that they prevent concussions, even though they always say wear mouth guards. I tell my kids to wear mouth guards, but it's mostly for dental and facial injuries. I think their teeth are important. It saves problems with lips and blood and everything going everywhere. So I like mouth guards, but in terms of preventing concussions, there's not good evidence that they are helpful. There they are now. Helmets. Same thing about helmets. They have evidence that they reduce the force to your brain, but I've not seen any studies that say they reduce the occurrence of concussions, believe it or not. So there's other factors that go with it, whether it's obviously if you didn't have on a helmet, you may not necessarily hit someone with your head. That may be part of it. But there's other issues that it's tough now to study no helmet versus helmet. So I don't know if we'll ever have the evidence, but I don't expect to go back to not wearing helmets.
Does it matter? Let's go back to my combatives. Big headgear, little headgear, foamy headgear.
Now I'd say of the stuff in terms of reducing impact forces, the problem football has is no one wants a bigger helmet. The bigger the helmet, the more they can reduce the force to the head. Like I said, when they do studies of helmets, they measure how much it can reduce that force, but it's not a direct linear correlation. I mean, if you get hit this hard, you're going to have a concussion. It's kind of dotted. It's not always direct. But you could say, if your concussion is in this window, and you can, or if you can reduce the window ever so slightly, you would think you would be able to reduce the risk of a concussion by a helmet. So that's the thought of using the helmets, even though there's not studies to prove that. The bigger the helmet, the more they are able to reduce the forces. Now, if you say, well, someone just has a giant helmet, that's terrible. But I would say that's the issue that football's having, for example, is they say, well, if we could make the helmets another inch bigger, you could reduce the forces that much more. Could that make a difference? I don't know for sure. But if you're saying the same type of helmet, does a bigger helmet help reduce that? Yes. But again, there's not evidence to show that it reduces concussion.
We're seeing children wear helmets who have seizures.
So that's going to be, a lot of that would be, say they have a seizure, they fall, hit their head on something. So there you're preventing, I guess, reducing the force, but you're also doing the kind of the skull fracture, scalp injuries, different things like that. But maybe the same idea with football. It's like if you are narrowing the window of getting a concussion, it may be worth doing. Here's some other things of interest recently. Dartmouth College in football, 2010, stopped tackling each other in practice. So they just don't do it. And they have all kinds of tackling dummies. If you look up on YouTube, the Dartmouth Way, they have some different tools and stuff that they do where they have different tackling dummies, but they don't do it at all. They tackle in a game and that's about it. Everything else, it's tackling dummies, pads, tackling technique. This is not an actual study, but he estimated an 80% reduction in concussions. So I would imagine over the years we will start getting reductions in time of hitting in football. Same thing with soccer. It's the head ball rule about that's the subconcussive blows, but that's also when most concussions happen. So for younger people, I could see them saying, okay, we don't want head balls up until a certain age, whether it's 14 or something of that nature, on the plays or the events that are most likely to cause a concussion. We're talking now, educating, speeding up here because I'm running behind. Here's some couple sources if you like to look. CDC has a good one, NCAA has a good one, NFL is trying to do some stuff, and then the Ohio, that's that one with the Ohio concussion law. We'll speed through the law. Is that all right? April 26, 2013, basically, parents, students that are playing an organized sport have to get an information sheet about concussions. We still do it with our college athletes here. Every year they come to school, they get the information sheet, they sign and say they got it. Coaches or referees must remove athletes that show signs or symptoms of a concussion. How coaches know that is they have to take a course every 3 years that explains signs or symptoms of a concussion. There is no return to play the same day an athlete is removed. So if a referee sees a symptom or sign of a concussion, removes him out, in theory he's not supposed to go back in that same day. If he is taken out, he is not able to return until he has written permission from a physician or authorized healthcare provider, which can be someone working in conjunction with a physician, someone in collaboration with a physician, something of that nature. It doesn't have to be a physician, but an authorized provider of the group or club that you're associated with.
Are you speaking of a nurse? Or?
A nurse practitioner may do it that is working with a physician, or if they have a working relationship, say the group or the club says, yep, she is our contact person, this person's also working with this person, it can be that. Talk about the online training for coaches and referees, and there's a couple of the courses. School accommodations, we talked about that. We are going to speed through these things. Here's a common note that I get for patients or that are students: allowing fluid, rest breaks, extra time, different things that we feel they may need. In severe cases, a 504 plan or 504B plan is a specific plan that may be in place to help them accommodate their changes. And in severe cases, we do have an IEP, which is an individualized education program, I believe. That is another one that's even more detailed in the 504. We talked about different medications here. I'm talking about half days or when they can return to school. 504, do that. IEP. Now, if you are extremely interested, like I said, the 5th International Conference on Concussion in Sport is going on this fall. So next spring, generally it'll come out. You'll see it in some of the newspapers or the evening news. They'll say, oh, the concussion statement has came out. And you can look at it online. It's meant, they'll probably have some new publications available to the public, something like a new recognition tool, something like that, that will be coming out next spring. So if you love concussions and you love thinking about it, that would be rather fun. Questions on that? Sorry that took longer than I thought. I added more slides and then got a little long.
Very informative, thank you.
All right, I'll be here for questions. You're free to go. Please take some snacks for family members, friends, something like that.